Now, the definitive treatment for hypothyroidism can be radioactive iodine and thyroidectomy as well. So, if someone has a recurrent disease, even on anti-thyroid medication, and if someone symptoms is not improved with anti-thyroid medication, then we can offer him or her radioactive iodine therapy as first line definitive treatment. But there are certain situations which are contraindication for radioactive iodine treatment. The first one is that during pregnancy, radioactive iodine is contraindicated. So if a pregnant woman symptoms does not improve with anti-thyroid medication, then partial thyroidectomy can be done, or surgery, which is partial thyroidectomy, that can be offered to a pregnant woman. What are the other contraindication for radioactive iodine treatment? The first one is pregnancy, and the second one is if malignancy is suspected, and the third one is if the patient has an active thyroid eye disease. So remember 4 contraindication for radioactive iodine treatment. The first one is pregnancy. Second one is if the patient has an active thyroid eye disease, because radioactive iodine can worsen the thyroid eye disease. That's why in thyroid eye disease and in it is avoided, and in pregnancy it can cause teratogenicity. That's why it's avoided in pregnancy. These are the two important contraindications for radioactive iodine therapy. The other two contraindication is if malignancy is suspected and if there are concern about compression, then radioactive iodine is avoided.
Sorry,
And if someone is
what was the fourth one? Concerns about?
compression,
Sorry, compression of what?
compression of the trachea, because thyroid gland is present in the neck region, and in
Oh,
large thyroid gland can compress trachea, which can lead to shortness of breath, stridor, compressive symptoms. So if there are concerns about compression, then radioactive iodine is not the first line, but surgery is the first line to
okay,
relieve the compression. So if there are
right.
concerns about compression, if malignancy is suspected, if the patient is pregnant, or if the patient has a mild disease, or if the patient has a active thyroid eye disease, then in these circumstances, uh, surgery will be our preferred choice. While in case of mild or moderate disease, anti-thyroid drugs will be our first line treatment.
So the surgery can be done when the patient is pregnant as well.
Yes, in pregnancy, if the patient's symptom does not improve with anti-thyroid medication, then partial thyroidectomy can be done
Okay, thank you.
in the second or third trimester.
Thank you.
So this was some the anti-thyroid drug that can be used in the treatment of uh, hyperthyroidism was carbimazole and propylthiouracil, and we have discussed different scenarios, that in which scenarios to use carbimazole and in which scenario to use propylthiouracil, and also the definitive treatment for or the first line treatment is radioactive iodine therapy, except in 5 situations that I have told you. Now, what are the nice guidelines for grave disease in young people and in children? Remember that in young people and in children, first line definitive treatment is anti-thyroid drugs for at least 2 years. But even if with treatment with anti-thyroid drugs for 2 years, there is a relapsed hyperthyroidism, then you have two options: either to continue the anti-thyroid medication or restarting the anti-thyroid medication or discuss radioactive iodine or surgery, total thyroidectomy or radioactive iodine therapy. If treatment with anti-thyroid drugs for at least 2 years and the patient has a relapse, then radioactive iodine or surgery or total thyroidectomy can be done. What are the complications of radioactive iodine or radioiodine treatment? Because radioiodine can destroy the normal thyroid tissue, so it can result in the most common complication of radioiodine treatment is hypothyroidism. In order to avoid this, thyroxine supplementation is given to prevent hypothyroidism. Again, some contraindication to radioiodine therapy. If someone has undergone radioiodine therapy, then she should avoid pregnancy 4 to 6 months following treatment. So no pregnancy after treatment with radioiodine for 4 to 6 months. And also patient under 16 years of age, in patient under 16 of year of age, radioiodine therapy is contraindicated. So these are the three important contraindications for radioiodine therapy: pregnancy, patient under 16 years, and patient with thyroid eye disease. Is it clear to everyone up to this point? The management of hyperthyroidism. The
Well,
definitive treatment.
the third one was patient has a thyroid eye disease.
Yes,
Okay.
because if a patient has a thyroid eye disease and he undergo radioiodine therapy, his condition will get worse. Researchers have shown that radioiodine can worsen the thyroid eye disease. So that's why patient with thyroid eye disease cannot undergo radioiodine treatment.
Okay. Thank you.
So in short, a short summary of management of hyperthyroidism is uh, if the disease is mild or moderate and the patient is young. In young patient with mild to moderate disease or even severe disease, uh, the first line management or the first line treatment is anti-thyroid medication for 2 years. And if there is relapse, then the second line is radioiodine or total thyroidectomy. While in adults or in older patients or in elderly and with severe disease, the first line definitive treatment is radioiodine or surgery, except if the patient is pregnant and if the patient has thyroid eye disease or if the patient age is less than 16 years, or if there is a suspicion of cancer or if there are concern about compression, then we'll avoid radioiodine therapy and we'll go for surgery. Now our next topic is subclinical hypothyroidism. So in primary hypothyroidism, T3 and T3 and T4 level were low and TSH was raised. What is subclinical hypothyroidism? Subclinical hypothyroidism. In subclinical hypothyroidism, TSH will be raised, but T3 and T4 will be normal. Unlike primary hypothyroidism, in which T3 and T4 were low because of decreased production of T3 and T4 by the thyroid gland. In primary hypothyroidism, T3 and T4 were low, but if T3 and T4 are normal and TSH is raised, then it is subclinical hypothyroidism. Remember that subclinical hypothyroidism can progress to hypothyroidism. There is a chance of about 2 to 5% per year that they can progress to hypothyroidism. What is the management of subclinical hypothyroidism? There are two scenarios. We will measure the patient TSH levels on two occasions with a gap of 3 months. Patient TSH level will be measured. And if the patient TSH is between 4 to 10 milliunit per liter, then we will consider treatment if the patient is less than 65 years and with symptoms of hypothyroidism. So basically, in the management of subclinical hypothyroidism, we have two pathways that depends on the level of TSH. TSH will be measured on two occasions with a 3-month gap. And if the TSH level is more than TSH level, if it is more than 10 milliunit per liter, then we will start treatment, even if the patient is asymptomatic. So TSH level more than 10 will start the treatment, even if the patient is asymptomatic. And if TSH level is below 10 but above 4, so if the TSH level is between 4 to 10 and the patient age is less than 65 years and if the patient is having symptoms, then we will start treatment, otherwise no treatment. Subclinical hypothyroidism. In subclinical hypothyroidism, T3 and T4 level are normal and TSH is raised. So if TFT shows, thyroid function test shows a raised TSH and low T3 and T4, sorry, normal T3 and T4, then it is subclinical hypothyroidism. How we are going to manage subclinical hypothyroidism? We'll measure the patient TSH level with a 3-month gap on two occasions. And if the TSH level is more than 10, then we'll treat the patient even if the patient is asymptomatic. But if the TSH level is between 4 to 10 and the patient age is less than 65 years with symptoms suggestive of hypothyroidism, then we will give a trial of levothyroxine. So this was all about the management of subclinical hypothyroidism and its diagnosis.
If the patient is over 65 years of age and is asymptomatic and is got 8 TSH, so will we start the treatment?
No.
No. Okay.
In asymptomatic patient, if the TSH level is below 10, then there is no treatment is given.
Even if the patient is over 65?
Yes. In old age patient, the strategy is usually wait and watch.
Okay. Thank you.
Anyone else have any question? Now our next topic is riddle thyroiditis. The only thing that you need to remember about riddle thyroiditis is that riddle thyroiditis is a chronic autoimmune disease which is a part of other systemic inflammatory illnesses. So that's why it will not be asked in endocrinology or in thyroid disease chapters. The only thing that you need to remember about riddle thyroiditis is that in riddle thyroiditis, due to chronic inflammatory diseases of the thyroid gland, the normal parenchyma of the thyroid gland is replaced by dense fibrous tissue, which leads to a stony, hard thyroid gland. And riddle thyroiditis can lead to, because there is the normal thyroid parenchyma is replaced by fibrous tissue, so it can be a cause of hypothyroidism, a very rare cause or less important cause of hypothyroidism. The most important common cause is Hashimoto thyroiditis, iodine deficiency, treatment with radioiodine or thyroidectomy, and riddle thyroiditis is a less important cause of hypothyroidism, in which normal thyroid parenchyma is replaced by dense fibrous tissue, which leads to a stony, hard thyroid gland. Thyroid gland become hard like a stone. So this is an important point to remember about riddle thyroiditis. It can only be diagnosed on biopsy. The definitive diagnosis is made on the basis of biopsy. The complication of renal thyroiditis include that it can compress trachea, so it can lead to signs of airway obstruction such as dyspnea. It can lead to hoarseness if it compresses the recurrent laryngeal nerve. It can cause hypothyroidism. It can cause hypoparathyroidism because of fibrosis of the parathyroid gland, because they are present on the posterior surface of the thyroid gland. Due to compression of esophagus, it can lead to dysphagia. Uh, this description is just for your knowledge. You do not need to remember all these about. Now, another important cause of hypothyroidism as well as hyperthyroidism is subacute thyroiditis or decurvane thyroiditis. There are four phases of subacute thyroiditis, is also known as decurvane thyroiditis, and also subacute granulomatous thyroiditis. You remember that in Plab1 exam, if a patient present to you with a painful enlargement of the thyroid gland after a viral infection, such as after a flu or upper respiratory tract infection, then you will suspect subacute thyroiditis. So patient with a history of painful thyroid gland or enlarged thyroid gland, painful and enlarged thyroid gland after a history of upper respiratory tract infection, then you will suspect subacute thyroiditis. Subacute thyroiditis, there are four phases of subacute thyroiditis. The first phase that usually lasts from 3 to 6 weeks. Remember that initially when there is inflammation of the thyroid gland, which is called thyroiditis, the rupture of thyroid follicles, there's a rupture of thyroid follicles which releases the stored T3 and T4. That's why in the phase 1 there will be hyperthyroidism and painful goiter. Thyroid gland will be enlarged and painful, and ESR will be raised in the first phase of subacute thyroiditis. Why there is hyperthyroidism in the phase 1 of subacute thyroiditis? because of the rupture of thyroid follicles and release of stored T3 and T4. In phase 2, that usually lasts for around 1 to 3 weeks, the patient will be euthyroid. So hyperthyroid and then euthyroid, and then because of inflammation and decreased function of the thyroid gland, the synthesis of T3 and T4 will be decreased. So in the third phase, there will be hypothyroidism. And the fourth phase is the recovery phase, in which thyroid structure and function goes back to normal. So the simple way to remember these four phases of subacute thyroiditis, one thing that you can see that subacute thyroiditis can cause hyperthyroidism initially and hypothyroidism in later stages. So the diagnostic point for the diagnosis of subacute thyroiditis include history of upper respiratory tract infection with painful enlargement of the thyroid gland, because it is an inflammation and inflammation leads to rupture of the thyroid follicles. So initially in the phase 1 there will be features of hyperthyroidism, and as T3 and T4 is the release T3 and T4 is metabolized gradually, then the patient will become euthyroid in the phase 2. And in the phase 3, as uh, the structure of the thyroid gland is destroyed, so there will be features of hypothyroidism. Phase 3 usually lasts for weeks to months, while in phase 4 there will be recovery. The thyroid gland will recover, its structure and function will go back to normal. In investigation, there will be reduced uptake of iodine 131, reduced uptake of iodine on radionuclide scan of the thyroid gland because of inflammation and hypofunctioning of the thyroid gland. There will be reduced uptake of iodine. Remember that the management of subacute thyroiditis is simple. Most of the patients do not require any treatment. In hyperthyroid phase, which is the phase 1, if a patient present to you in the phase 1, then you will not choose antithyroid drug as a treatment choice for treating subacute thyroiditis. The only drug that you can give in hyperthyroid phase in subacute thyroiditis is propranolol for the management of tachycardia. No other treatment is required if patient present to us in the hyperthyroid phase. You do not need to give any antithyroid medication to the patient with subacute thyroiditis. Remember that there are two thyroiditis in which antithyroid medication are not given. One is subacute thyroiditis or decurvent thyroiditis, and the second one is postpartum thyroiditis. Postpartum thyroiditis, which is developed after the delivery of the baby. Postpartum thyroiditis and subacute thyroiditis, both of them are self-limiting. So they do not require any treatment with antithyroid medication. Don't forget this point. This is a very important point to remember, because it was tested in the August 2020 exam, 2021. Pain could be treated with aspirin and other NSAIDs. And if hypothyroidism develops, then you, in the third phase, you can see that the patient with subacute thyroiditis develop hypothyroidism. So you will not treat hypothyroidism with levothyroxine. Instead, you will treat it with steroids, because it's hypothyroidism is due to the inflammation of the thyroid gland. So we'll use steroids instead of levothyroxine. So no thyroid medication are given in subacute thyroiditis. Is it clear, everyone? Now, some feature of thyroiditis is thyroiditis disease is present in 50% or 25% of the patient with grave disease. The feature of thyroid disease include exophthalmos, ophthalmoplegia, optic disc swelling, conjunctival edema, and inability to close the eye because of lid lag and lid retraction. And because the patient has an inability to close the eyelids, so the eyes can become sore and dry. And if they are untreated, the patient can develop corneal or conjunctival ulceration. The management of thyroid eye disease is steroids and topical lubricants to prevent corneal inflammation, and the definitive management is surgery. What you need to monitor in patient with established thyroid eye disease, you need to, if any of the following signs are present, then you will refer the patient to an ophthalmologist. What are the signs that will prompt a referral to an ophthalmologist? If there is any corneal opacity and the cornea is being visible even when the eyelids are closed, there is disc swelling, unexplained deterioration in vision, change in the intensity or quality of color vision. So in all these cases, you will refer the patient to an ophthalmologist. Now some interpretation of thyroid function tests. Low TSH, high T4, T4 high, TSH low, it's thyrotoxicosis. And the most common cause of thyrotoxicosis is Graves' disease. If T4, free T4 is low and TSH is high, then it is primary hypothyroidism. And if both of them are low, then it is secondary hypothyroidism. If TSH is low and T4 is low, then it means the low T4 is due to low TSH due to some pituitary disease. So it will be secondary hypothyroidism. And as secondary hypothyroidism is due to a pituitary disease, so sometimes there is an associated steroid deficiency due to decreased ACTH, adrenocorticotropin hormone, which is also secreted by the pituitary gland. So if a patient of secondary hypothyroidism presents to you, then first replacement steroid therapy is done and then thyroxine will be given. So patient with secondary hypothyroidism are given steroids because of two reasons. The one reason is that sometimes there is an associated deficiency of steroids, cortisol, and due to low level of ACTH because of problems in the pituitary. TSH is low, so there can be low cortisol or due to low ACTH. This is the first reason that you need to give steroids to patient with secondary hypothyroidism. And the second reason is that thyroxine therapy can lead to increased metabolism of cortisol. So the patient can develop deficiency or adrenal insufficiency or even adrenal crisis due to thyroxine therapy, because thyroxine will causes an increase in the metabolism of cortisol. That's why in secondary hypothyroidism, steroids are given along with thyroxine. Now there is another condition in which low TSH is low and free T4 is also low. This type of uh, thyroid function findings can be present in sick euthyroid syndrome as well. Sick euthyroid syndrome. Focus on its name. Sick euthyroid syndrome. Euthyroid mean thyroid is functioning normally. Thyroid is functioning normally, but T3 and T4 and TSH level are low. So this condition is known as sick euthyroid syndrome, in which thyroid function is normal or thyroid is functioning normally, but T3, T4, and TSH level are low due to some other reasons or some non-thyroid reasons, such as severe infection, or patient who are admitted in critical care unit or intensive care unit. They can have free T4, T3, and low level of T4, T3, and TSH. This is known as sick euthyroid syndrome. So if in the Plab1 exam they ask you a scenario like this, that a person is admitted with a severe pneumonia in intensive care unit, what will be the findings of thyroid function test? So the answer will be low TSH, low T3, and low T4. In some cases TSH may be normal, but in most cases TSH is low. All three of them are low. And treating the underlying cause such as pneumonia or infection, usually after treatment, the thyroid function test become normal. Now another scenario of subclinical hypothyroidism in which TSH is high and T4 is low, normal. So there are three situations in which TSH is high. One is primary hypothyroidism, one is subclinical hypothyroidism, and the third one is poor compliance with thyroxine. These are the three conditions in which TSH is high. So a high TSH with low T4, it's primary hypothyroidism. And the other two scenarios, high TSH with normal T4, it can either be subclinical hypothyroidism or it can either be poor compliance with thyroxine, because the patient who are on thyroxine therapy, they usually take thyroxine when their test is going to be performed. Just 1 or 2 days before the test, they start taking thyroxine. So that's why their free T4 level are normal, but TSH is high. So a high TSH and normal T4, it can be subclinical hypothyroidism or it can be poor compliance with thyroxine. How you are going to differentiate between these two? In poor compliance with thyroxine, if on TFTs there is high TSH and free T4, they will mention that the patient was diagnosed with hypothyroidism and he was started on thyroxine or levothyroxine, but his TSH level are high and T4 level are normal. What is the most probable cause of his thyroid function test? High TSH level, then you will select poor compliance with thyroxine. So this was all about thyroid function tests and their interpretation. Two conditions in which TSH is low. One is thyrotoxicosis and other is sick euthyroid syndrome. Low TSH and high T4 thyrotoxicosis, low TSH and low T4 sick euthyroid syndrome. Three condition with high TSH with low primary hypothyroidism, low TSH with low T4 secondary hypothyroidism, high TSH with normal T4 subclinical hypothyroidism, or poor compliance with thyroxine if the patient has a history of diagnosis of hypothyroidism and he was started on thyroxine, but his TFTs, which are done 3 months after the startment of levothyroxine, shows high TSH and normal T4, then it's probably poor compliance with thyroxine. Is it clear, everyone, up to this point? Does anyone have any question? No questions? So this was all about thyroid related disorders: hypothyroidism, subacute thyroiditis, and one other thyroiditis was postpartum thyroiditis. The important point to remember is that in subacute thyroiditis and postpartum thyroiditis, antithyroid medications are not used. Only symptomatic treatment is done. Propranolol for tachycardia and NSAIDs for pain. No other treatment is required. And if the patient develops hypothyroidism, then steroids are used. While in postpartum thyroiditis, if a female present with features of hypothyroidism, then levothyroxine can be tried in postpartum thyroiditis, not in subacute thyroiditis. What is the reason of amenorrhea with hypothyroidism? Remember that hypothyroidism is associated with